This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Hi friends. This is a seemingly innocuous looking case. I'm doing hydrodissection very gently. And then you have this. Well, this is the first sign. And you guessed it right. It's IFIS. So let's talk IFIS today. Intraoperative floppy iris syndrome is an intimidating scenario for most of us. A typical case would behave something like this. The pupil is alright to begin with, and during the course of the surgery we have the situation of the iris trying to prolapse out of the incisions, and we have intraoperative meiosis, and the entire surgery then becomes quite challenging. Hence we need to have a definite game plan when we operate on such cases. In this video, I'll be sharing my strategy while dealing with a patient who has the potential to develop IFIS. This is a 72-year-old male patient who is on tamsulosin for the last 1 year. Apart from this, he is also on other drugs for hypertension and diabetes. I prefer to use atropine eye drops, 1 drop 2 times daily, 2 days prior to the surgery. I believe this helps in maintaining the intraoperative mydriasis, and it is usually stopped immediately after the surgery. The patient takes all his routine medications including tamsulosin. I believe stopping it won't help, so there's no point in stopping it. And surgical planning, I am ready with these tools here: dispersive OVD, the BHEX ring, iris hooks, which I may not use at all, but I just keep them ready. And 0.3 ml of adrenaline is mixed in the 500 ml of BSS which you're using for the surgery. Now moving on to the surgery, the first thing which I do is to make smaller side ports and having a slightly longer corneal tunnel. This is less than 0.9 millimeter in size, and I've not completely gone inside. This is an Alcon MVR side port which has much more smaller than my routine MVR blade, which is bigger. This is around 1.2 millimeter incision. I'm staining the capsule even though it's not a white cataract, since I thought it would be helpful to visualize the anterior capsule in the event of an intraoperative meiosis, and I'm forced to use a pupil expansion device then. This case is being done under topical anesthesia plus intracameral preservative-free lidocaine. I'm using dispersive OVD, that's viscoat-like substance. I'm using RO coat here. I don't overfill the chamber, and this is critical. The pressure is just around physiological. Okay, now why dispersive OVD and why not cohesive OVD like something like sodium hyaluronate or HPMC? Dispersive OVD has the advantage that it maintains the chamber and stays inside for long, and it just makes the iris behave a little better. Creating the main 2.8mm incision is extremely critical. It has to be perfectly sized, and it has to have a long intercorneal tunnel, and this incision looks good. Time for the rhexis. Rhexis is easy. Pupil is doing well until now, there is no issues, but I need to anticipate to go down once the hydrodissection is done. The way we do hydrodissection is critical in these eyes. The aim is to minimize the raise in the intracapsular bag pressure, because this is the first step which actually starts the cascade of events which eventually lead to the iris misbehaving and becoming floppy. First thing I need to do is to find the right plane just under the capsule, and I need to use as little fluid as possible to achieve a good cortical cleaving hydrodissection. Now we can see there is a slow, gentle wave confirming a possible good hydrodissection. I gently nudge the nucleus to release some of the trapped fluid and then confirm its mobility. I usually do this step for most of my cases. It's just sort of my habit, but it serves well in such soft cataracts. Now is the time to Feco. Now a few principles to understand, and these are going to be different from our usual cases. The first will be to perform a low flow, low pressure surgery. I'll be using low bottle height in most of the steps of emulsification, and second would be I would be avoiding a second instrument in most of the situations. Now, just take a note at this point, the bottle height is set at just 30 centimeters. I'm beginning to aspirate the superficial epinucleus. My plan is to perform a stop and chop technique. Again, as I begin sculpting, please take a note at the settings here. The bottle height is kept very low at 30 centimeters, and these are my AFR and vacuum. They're also low, compensating for the low inflow. Now again note, there is no second instrument involved during sculpting. I don't want to open up the side port at this stage. So once the sculpting is done and we've reached the adequate depth, now is the time to go ahead and divide. Now this is the time where I need to use a second instrument. The second instrument is introduced, and this is the time when there is a chance of the iris coming out of the side port. The smaller size side port is helpful to minimize this issue, and the bottle height is still maintained at 40 centimeters. Mind you, usually most of us, for routine cases during chopping maneuvers, we use a bottle height of 70 to 100 centimeters. The nucleus is soft, luckily, and chopping is very easy and it comes out without any fuss. And I'm holding the nucleus more anteriorly than I usually do, since this is a soft nucleus. If I go deeper to hold the nucleus, I'm afraid the fluid currents from the irrigation sleeve could potentially go below the iris and cause billowing of this floppy iris. So I'm trying to be as anterior I can be, but still be able to divide the nucleus quite easily. The 4 pieces are good enough. As soon as I come out, at this stage there is a slight hint the iris is trying to come out through the main incision. The pupil also has gone down marginally. Again, I go ahead and inject dispersive OVD first, which is coating the iris and also pushing it back gently. And beneath it in the antechamber, I'm just using a little bit of HPMC underneath it. Now moving on to the quadrant removal. Again, note the bottle height. It's about 50 centimeters. The emulsification will be done just using with one hand again. So I'm avoiding the use of second instrument to the side port, and this step will totally block the typical flow of fluid through the side port, which would in fact bring the billowing iris towards the side port incisions. Now note another important point here. The plane of emulsification is being done very anteriorly. My probe is above the iris plane. The fluid currents are not flowing under the iris, hence it's not being pushed out of the wounds. The nucleus is soft and there is minimal turbulence because of the low flow rate we are using. The first half is removed and similarly the second half is removed. So the emulsification was very easy. The 2 principles which we followed was using one-handed technique and bringing the pieces out of the bag and into the antechamber and emulsifying them very gently. Now is the time to remove the epinucleus, again which was done quite easily. And finally, time to remove the cortex. Again, during cortex removal, we are using low fluidics, as much of a low flow as possible without compromising the chamber depth and its dynamics. Once it is done, the intraocular lens is placed into the bag, and now is the time to remove the OVD in a similar process. See, the only price we have to pay for following this low flow, low pressure surgery is time. So every step takes almost twice the time because the flow rate is low, everything is low, but I feel it's worth it. This case took me around 25 minutes to complete, but there are no intraoperative difficulties. Of course, the cataract was soft. The iris did behave well. But let me show you another case of IFIS which had not been planned, since the patient had not revealed us the history of him taking tamsulosin. Now this is a patient who is 75-year-old male, and since we are not aware of him taking tamsulosin, I have not started him on preoperative atropine drops, and we have this relatively small pupil to begin with, and somehow on the look of it I'm suspicious about the iris in the pupil. It was more looking like an elastic pupil. The incisions are made slightly bigger. They're about the routine ones which I make 1.1 to 1.2 millimeter. But the main incision is quite good with a nice corneal tunnel. I'm using PHEX device for pupillary expansion. The rhexis is done and hydrodissection is performed. Since I've not thought about this case being an IFIS one, I'm using the usual bottle height during Feco emulsification. And also, I'm using the usual bimanual way of emulsification. See, most of the maneuvers are being routine, and the bottle height again is a routine one. We are using the routine bottle height of 90 to 100 centimeters here. Now in a few minutes, I can see that the iris has started to nudge towards the side port. It is stuck under the side port actually. Although the BHEX device is doing a great thing in holding on to the iris and it is acting like a retainer for the iris, but the leaky wound and the high infusion pressure ensures that the fluid current carry the floppy iris towards the leaky wound. So we need to understand that there are these combination of multiple factors which worsen the situation in a case of floppy iris. In this case, maybe after some time I realized this is a possible case of IFIS. I again switched back to low flow, low pressure surgery using a low bottle height during subsequent maneuvers. And the case could be completed with minimal trauma to the iris. And this is how the pupil looked the next day. To conclude, after demonstrating how the iris would behave differently in these two different cases, I would prefer to use the following strategies while dealing with an IFIS patient. I believe there's nothing like one single trick, but it has to be a multi-pronged approach for IFIS. Number 1. Pre-operative atropine eye drops before the surgery. Continued tamsulosin stopping won't help. Using smaller side port incisions with longer tunnel. A perfectly sized main incision with long intracorneal tunnel. Dispersive OVD is better, but it's critical to always underfill the chamber. Hydrodissection using as little fluid as possible. Feco emulsification using the principle of low flow, low pressure surgery. And this is achieved simply by bringing down the bottle height and decreasing the AFR and vacuum to suit the infusion pressure and volume. Using a single-handed technique during most steps of emulsification, although for harder nucleus it is not possible. Lastly, an antiplane of emulsification. I would always not hesitate to use pupil expansion devices at the earliest sign of any intraoperative difficulty. That's it. Thank you for watching and hope this helps.